In the following video, I'm going to give you a summary about the laboratory diagnosis of the plasma proteins and the plasma enzymes, especially in the medical concept. Now, what are the functions of the plasma protein? I bet you already know it. But for example, there are very serious of the function that the protein they do have in our body. For example, transport. Mostly in endocrine system when we do have some binding protein, hormone binding protein, such as the thyroxine binding globulin that binding the thyroid hormones, or apolipoproteins that causing and carry the cholesterol and triglyceride, the transferrin that carries the iron, and there are zillions of other proteins. The humoral immunity is going to depend on immunoglobulin or enzyme, renin, clotting factors, complement proteins, and some protease inhibitors such as the alpha-1 antitrypsin or ceruloplasmin, or maintenance of the oncotic pressure, mostly the whole protein, but particularly the albumin has a very important role in it. And the buffering capacity, mostly the albumin does have an important role in it. Let's see what will happen when we do have a changes of the total protein concentration. The normal range is ranging from 60 to 80 gram per liter. We are going to talk about hyperproteinemia if the concentration is higher than 80 gram per liter, or hyperproteinemia when the concentration is less than 60 gram per liter. What can increase the protein concentration in our body? Basically, when we do have an increased protein synthesis, that's for example in gamma globulinemia or paraproteinemia and monocular gammopathies. Or when we do have dehydration, when the volume of the distribution decreases. Or artifactually, when the hemoconcentration due to the stasis of the blood during the venipuncture. This all can cause a hyperproteinemia. Hypoproteinemia mostly is due to when we do have a decreased protein synthesis, such as a malnutrition, malabsorption, or liver diseases, but when we do have an increased excretion or the catabolism increases, such as for example protein losing state, such as a nephrotic syndrome, or catabolic stage when we are going to catabolize the protein. But when we let's see the volume that is distributed let's see the protein in, it's going to increase. Overhydration, increased capillary permeability. This is what we'll do have. Very importantly, when we measure the plasma or when we measure the serum, usually they are not the same. In the plasma, we do have about 2 to 6 gram per liter higher protein concentration due to the presence of the fibrinogen. Now let's see how this protein composition is going to be altered in our body. These are the pathologic changes of the plasma protein. What do we call as a dysproteinemia? The dysproteinemia is called when the total protein concentration is normal, however, the ratio of its component is changed. This is going to happen, for example, in acute or chronic inflammation, or other situation when we do have an increase of certain number of protein that's normally part of the protein composition in our body. Defects dysproteinemia is called when we do not have a certain plasma protein. For example, there is a disease when it's very rare, but we do have the lack of albumin, or lack of alpha-1 antitrypsin, or ceruloplasmin, such as in Wilson disease, for example. Paraproteinemia when there is a protein that's normally does not detected in our body, and mostly this can be seen in monocular gammopathy, and when we do have an abnormal monoclonal immunoglobulin or the portion of the immunoglobulin that increased in our body. How can we test the serum composition? What we do have, that's a serum electrophoresis. In serum electrophoresis, we do have a gel and we put the serum in it, and after we are going to put, let's see, the electrode in the two portion, the proteins are negatively charged in the alkaline medium, and therefore it's migrate to the anode in the electrode field. The separation of based on the charge difference between the protein plus the molecular size. There are many forms of electrophoresis. There are paper, agarose, cellulose, acetate, polyacrylamide. After staining the proteins, we do have engineered a fraction that evaluated by densitometer. Now these fractions that we can separate, for example, by using a serum electrophoresis, there are, let's see, 5 major fractions we do have. We do have the biggest one, that's an albumin, after the alpha 1, alpha 2, beta, and the gamma. This is a densitometric evaluation of the density of these proteins. However, in one band, we do have more component, more protein in it. For example, in a gamma fraction, we will find the fibrinogen, immunoglobulins, and C-reactive protein. Such as in a beta fraction, for example, or a gamma, we can find beta lipoprotein, C3 component of the complement cascade, plasminogen, transferrin, hemopexin, and another one, for example, in the alpha 1, alpha 2, that we do have the alpha 2 microglobulin, ceruloplasmin, haptoglobins, or alpha lipoproteins. In the alpha 1 fraction, the alpha 1 antitrypsin, alpha 1 acidic glycoprotein, and the albumin, and we could have a little other band here before the albumin, and that's called the pre-albumin binding. Now this is all the table is going to summarize that already mentioned in the previous slide, in which fraction we do have in which kind of protein in it. For example, in alpha 1 globulins, pre-albumin, albumin, alpha antitrypsin, or alpha acidic lipoprotein, and the beta alpha 2, the haptoglobin, alpha 2 microglobulin, and so on, and so on. Let's see the major plasma proteins. The biggest amount of protein that we do have in our blood, that's an albumin. The concentration is ranging from 35 to 50 grams per liter. Hyperalbuminemia usually is due to dehydration when we lost, for example, fluid, mostly water, in hypotonic solution, in sweating, or that evaporated. And we could have, for example, hypoalbuminemia that mostly due to the synthesis problem or loss of protein, such as a liver disease in cirrhosis, for example, or nephrotic syndrome. But malnutrition or oxidative enteropathy and albuminemia is very, very rare. Albumin globulin ratio, that's when we are comparing the albumin, that the first peak, and another alpha 1, alpha 2, and another globulins, that's a globulin fraction. That's they used to measure it, and this ratio is ranging from 1.2 to 2.5. In any kind of alteration, a decrease of albumin or increase of globulin due to inflammation, that ratio is going to change, going to be altered. It usually decreases. It decreases, as I mentioned, inflammatory diseases, liver diseases, malnutrition, burns, diarrhea, nephrotic syndrome, lymphomas, and myeloma. The prealbumin, the name comes from the electrophoretic separation because this band can be found at before, let's say, the albumin peak. It's produced by the liver cells, and that's a transport protein, usually binds retinol and transport thyroxine. It's a very good indicator of acute liver failure, and the reduction in protein intake, usually this is used in neonates, especially used in neonates because low half-life it has. That's a negative acute phase protein, similarly to the albumin. So it's meaning when we do have an inflammatory reaction, albumin and prealbumin level decreases. This is why it's called negative acute phase protein. Other thing is the acute phase protein, such as the CRP or C-reactive protein. That's usually as detected during inflammatory reactions, and this protein, the concentration ranging from 1 to 8 milligram per liter, but in a case of, for example, of cardiovascular heart diseases, it's better to have, let's say, around 1 or maximum of 3 because they have an independent risk factor for coronary sclerosis or atherosclerosis. This is produced by the liver cells that's binding to the surface of the bacterial wall and causes the swelling and agglutination of them. In addition, the CRP plays an important role in the fixation of the complement system. Thus, induces the formation of C3b, the opsonin, and other chemotactic factors. The disease marked a marker of the infection, inflammation, trauma, burn cells, cancer, and diseases. Usually, its names refer to the precipitation of the pneumococcal C polysaccharide. If you compare, for example, the changes of the erythrocyte sedimentation rate and the CRP increases much earlier and usually is ending earlier. So to follow, for example, detect the inflammation, usually bacterial or other kind of infection, is much better than a erythrocyte sedimentation rate, and the efficacy of the therapy can be monitored very fast. It doesn't take too long. Within 1 week, it's already going back to the normal level. The acute phase protein 2, such as a procalcitonin, this is what usually using to measure the bacterial and fungal infection. This is produced by the C cells of the thyroid gland and after the proteolytic digestion converted to calcitonin. The plasma level may indicate, as I mentioned, bacterial and fungal infection. The increase of the procalcitonin is sooner than indicated by the CRP and it's more specific and sensitive as well. Ceruloplasmin. Ceruloplasmin that produced by the white blood cells did a major role to transfer copper and free radical scavenger. The low level in Wilson syndrome, for example, Wilson diseases. Acute phase reactant proteins such as the interleukin 6 get a very good prognostic indicator of systemic inflammation and neonatal sepsis detected by ELISA, and relatively that's an expensive test. Alpha-1 antitrypsin that's produced by the liver cells, the most important protease inhibitor, glycoprotein, forms complex with the serum proteases such as the trypsin, chymotrypsin, collagenase, plasmin, thrombin, and inactivates them. This is emphysema. If I want to refer to the emphysema or COPD, that's, for example, alpha-1 antitrypsin deficiency can cause emphysema. A congenital absence is caused neonatal hepatitis and liver cirrhosis. In adults, severe pulmonary emphysema may develop due to the insufficient inhibition or elastase in the white blood cells, mostly the neutrophil granulocytes. Beta-2 microglobulin that's used as a tumor marker. In the next series, when we are talking about the tumor markers, I will mention some about it. They're measured in the urine as an indicator of the tubular function because that's a low molecular weight protein and every protein is filtrated. However, the proximal tubules reuptake in this microglobulin. So if you do have an elevation in the urine, that indicates some tubular problem. If you do have an increased circulatory level, that usually as a tumor marker, mostly that's, for example, in multiple myeloma, the level can be increased. So this beta-2 microglobulin is used to measure, for example, estimate the GFR. I want to refer to the kidney practice that you can watch in the YouTube video as well. Myoglobin, that oxygen-carrying hemoprotein of the muscle. In acute myocardial infarction, the plasma level increases in 1 to 2 hours after the pain occurs. However, it's not so specific one, especially if somebody got already injection or muscle injection or any kind of muscle damage, the myoglobin level can be increased. That's a good indicator of muscle diseases or muscle injuries. But be aware because it can be elevated in renal impairment as well. Transferrin, that the liver produces this enzyme and transfer iron in anemias, the lecture of anemias, and the negative acute phase protein. So far we do have negative acute phase protein, the albumin, prealbumin, and the transferrin. Ferritin, this is how the iron stored in our body. The composed of the apoferritin and numerous iron molecules. Determination of this important test of iron metabolism, see anemia. This is a stored iron. In latent iron deficiency and excessive iron intake can also be detected. Serum concentration is a saturation indicator of the iron stores. If it's decreased, first the stores depleted. Haptoglobin. In anemias, if you do see in the bilirubin metabolism, usually haptoglobin level decreases when we do have an intravascular hemolysis because haptoglobin is going to bind the hemoglobin, and after being bound to this hemoglobin is being uptaken by the macrophages, reticular endothelial system, and converted to the bilirubin. The serum concentration increases its inflammation and trauma, and this is an acute phase protein. Immunoglobulin, they are distinguished by the type of the heavy chain, such as the IgM, IgA, IgD, IgE. The mean concentration is listed right here. And we do have a hypogammaglobulinemia, for example, in malignant hematological diseases such as the chronic lymphoid leukemia, multiple myeloma, and Hodgkin lymphomas. Cytotoxic treatment, severe nephrosis, or IgA deficiency is the most common inherited forms. Hypergammaglobulinemia, such as in autoimmune diseases, such as systemic lupus erythematosus, or chronic infection, liver diseases, cirrhosis, or chronic active hepatitis. The complement proteins, C3C4, that's measured most commonly. The C3C4 level decreases in bacterial infection, systemic immune complex diseases, and glomerulonephritis when the complement cascade is activated, and this is how it's used up. The C1 esterase inhibitor analysis of the complement system may reflect genetic diseases. Let's see how can we evaluate an inflammatory diseases. First of all, the temperature. Subfever or fever, that's a hallmark of inflammatory diseases. The white blood cell count that usually elevates, that's the qualitative and quantitative. The CRP could be measured immediately to showing that that's an inflammatory reaction. Erythrocyte sedimentation rate is an specific indicator, and it could be altered by a lot of things I'm going to talk about later on. Procalcitonin, as we mentioned, in severe bacterial or mycotic and parasitic diseases, and also in sepsis increases, and much earlier in the CRP. In case of the plasma protein effect, that's albumin, the immunoglobulin, the IgM, IgA, IgG, and the globulin albumin globulin ratio decreases, and in the protein electrophoresis we do have an alpha 1 alpha 2. In acute infection usually we do have an increase of the IgM, and later on we do have the IgG. Now these are the acute phase proteins, that is a systemic reaction of the inflammation usually produced by the liver, such as the positive one, alpha 1 antitrypsin, fibrinogen, haptoglobin, ceruloplasmin, and CRP, and the negative acute phase proteins such as the prealbumin, albumin, and the transferrin. Erythrocyte sedimentation rate, or this name is Westergren. Now, this test was introduced as a pregnancy test because during pregnancy, the erythrocyte sedimentation rate increases tremendously, and this is how they introduced this test. However, after that, they figured out that any kind of changes in the serum composition that's going to alter the sedimentation of the red blood cells. So what's going to alter, let's see, the red blood cell sedimentation? First of all, one thing, the charges. Normally, if the red blood cells are separated from each other, relatively the all has negative charge, surrounding negative charge, because the albumin is surrounding the red blood cells. So this way we do have an electric field that usually they don't let them to clamp. However, when we do have, for example, an increase of the globulins, decrease of albumin, there are more positive charge can be located on the surface of the red blood cells, and this positive charge is going to electrostatically, let's see, getting close to these red blood cells. So, and this way they are clamping together, and this is why the total surface area is going to decrease comparing to the separated cells, and this is why the sedimentation rate be faster. The normal sedimentation rate in men about 2 to 10 millimeter per hour, in women 2 to 20. In women is a little bit higher one because the fibrinogen level is higher in women. Now what's going to influence the ESR? Size of the red blood cell, viscosity of the plasma, and the zeta potential, that is the charge that is surrounding red blood cells. The asymmetric proteins such as the fibrinogen decreases the zeta potential, as I mentioned, because they have different charges. Now what can alter the ESR? First of all, inflammatory diseases, hypoalbuminemia, hyperglobulinemia, necrosis, pregnancy, tumor, anemia, age, usually by age it increases, or heparin as an anticoagulant, temperature, and age of the sample. So this is why you have to measure immediately the samples. You cannot let the samples to stay too long, because that's going to increase or alter the sedimentation rate. So the ESR is not a specific test. It won't tell you what the cause is. It's only we can see that something changed in the plasma composition. That can be tumor, infection, or any other problem, and after you have to figure out and have to prove it. This is why in acute inflammation the CRP and the procalciton is much better way to detect it. But it's still in use because the physician like to know whether everything is under control, and if they could explain why the ESR is decreased, they don't have any problem. However, if there is no other clinical sign, you have to figure out, you have to, let's see, search for different, let's see, causes. Let's see how this serum electrophoretic pattern looks like in various diseases. We mentioned first, for example, in normally and in acute inflammation. That's a green line, represents the densitometry of the normal plasma protein. In acute inflammation, as we mentioned, that the albumin level decreases, while the alpha-1 and alpha-2 band, it will increase. In a case of chronic inflammation, albumin decreases further, and beside of the alpha-1 and alpha-2, the gamma portion is going to elevate it as well. In, for example, monoclonal gammopathy, what we do see in the gamma fraction, we do see a narrow band peak. It's peaking, it's meaning that we do have similar type, similar molecular weight, similar charge protein in this fraction. In hypogammaglobulinemia, when we do have a problem with the immunoglobulin synthesis, this gamma fraction is flattened. In liver cirrhosis, that is a very characteristic feature of it's called the beta-gamma bridge. This is due to the abnormal synthesis of the albumin because the liver is not able to synthesize the alpha-1, alpha-2 and the albumin, but we do have an IgM and later on IgG increase because the immunoglobulin release is still normal, and this is why the ratio, albumin globulin ratio, is decreases. So that's very, very characteristic of a cirrhotic patient.